started. I'm Dr. Melinda Ring. I'm the director of the Osher Center for Integrative Medicine at Northwestern University, and welcome to this joint presentation. It's sponsored by the Osher Center along with IPHAM. Today I have the great honor of introducing my fellow, Dr. Amrien Ghouse. Dr. Ghouse is trained in family medicine and now is in her second year of the Integrative Medicine residency, the Integrative Medicine Fellowship training program at the Osher Center. Her interest in integrative medicine comes from her desire to find creative solutions to disease prevention and barriers to her patients' wellness. She often uses her osteopathic and integrative background to identify and address the root cause of her patients' concerns. She enjoys guiding patients to the realization that despite their circumstances, they can make positive changes that directly impact their health. Her interests include addressing healthcare disparities, functional medicine, and implementing osteopathic manipulative medicine. And today, she's going to be sharing with us her perspective on osteopathic manipulative medicine and what its role is in the healthcare system of today. So with that, I will turn it over to Dr. Ghouse. And just to note that she will be doing Q&A at the end, and to please use the Q&A instead of the chat for posting any questions, and feel free to do that throughout the presentation as things come up. And she'll do her best to address as many as possible at the conclusion of her presentation. And with that, I will turn it over to you.
Hello, everyone. Thanks for joining. Oops. I'm Amrien Ghouse. Like Melinda said, I'm the Integrative Medicine Fellow at the Osher Center. And feel free to shoot me an email at amrien.ghouse@northwestern.edu if you have any questions that I can't get to towards the end of this. So some of our objectives today are to become familiar with the history of osteopathic medicine and the philosophy behind it, recognizing some of the benefit of OMT and its use for common musculoskeletal complaints, understanding some of the principles behind osteopathic manipulative treatment, and demonstrating some of the knowledge and evidence for the efficacy and safety of OMM. I might use OMM, which stands for Osteopathic Manipulative Medicine, and OMT, which stands for Osteopathic Manipulative Treatment, interchangeably. Okay, so a brief history. Osteopathic medicine was founded by Dr. Andrew Taylor Still in the 19th century. He was a Civil War doc that was actually an MD that was disillusioned with the medical practices of the day. He was also an anatomist and theorized that obstruction of blood flow, sometimes misalignment of spinal segments, could eventually interfere with nerve function, blood supply, and eventually manifest as disease. He found that treating multiple medical conditions by palpating dysfunctional areas and using a manual manipulative treatment with his hands helped alleviate a lot of the diseases of the day that weren't adequately treated with the medicine of the time. The school he founded is actually where I attended in Kirksville, Missouri. It's now known as A.T. Still University, but initially in 1892, it was called the American School of Osteopathy, and this preceded any chiropractic schools. This is basically a rundown of Andrew Taylor Still's philosophy of medicine. He really was a proponent of theorizing that structure and function had a huge role to play as far as anatomy and physiology went, and eventually led to the development of disease. So the American Osteopathic Association defines osteopathic medicine as a complete system of healthcare. It combines the needs of the patient with the current practice of medicine. It is based off of 4 major tenets. All of these are incorporated into many physicians' assessments of patients and their individualized treatment plans for patients. So the tenets are as follows. The body is a unit. And the person is fully integrated being of body, mind, and spirit. The body is capable of self-regulation, homeostasis, self-healing, and health maintenance. Structure and function are reciprocally interrelated, and then rational treatment is based off of an understanding of all of the previous principles. A lot of the osteopathic manipulative treatment and manipulative medicine component is really tied closely to the structure and function tenet. This goes a little bit further into 5 basic models that break down what a person can have as far as dysfunction. So the first is a biomechanical model, which looks at a patient from a structural or mechanical perspective. So an example of this would be a patient that was in a motor vehicle accident that suffered from whiplash. Often they'll present with complaints of pain in their neck, sometimes low back pain, sometimes rib pain, sometimes shooting pain over relying where the seatbelt was. And this can also manifest as lightheadedness, dizziness, paresthesias, and all of those symptoms can lead to structural issues that cause motion restrictions, which will eventually lead to affected physiologic function. So treatment of somatic dysfunction in this patient would involve restoring their normal posture and motion in the areas that were noted to be dysfunctional, and eventually that leads to improvements in breathing, circulation, improved appetite, and overall the patient would eventually feel better with like improved energy, sleep, that sort of thing. The respiratory circulatory model is another way of looking at dysfunction within patients. It maximizes the capacity and efficiency of the respiratory and circulatory mechanisms within a person's body. One of the examples of this would be a person that has pneumonia, which can lead to congestion in the lungs. The coughing can lead to pain with breathing. All of that signals the nervous system to accommodate with decreased respiratory capacity, which leads to persistent infection. So treatment in patients with respiratory complaints, pneumonia, asthma, things like that, involves focusing on restoring normal motion and function of all of the anatomic structures involved in the areas that have perceived dysfunction. The neurologic model is composed of the influence of different spinal mechanisms. So a lot of the time, this may be a physical malrotation or misalignment of separate vertebral functions or segments. And this can have an underlying effect on proprioceptive function, pain fibers, and the overall neuroendocrine and immune network. An example of this is post-operative ileus. It's pretty common for patients to be constipated following a major surgery after having anesthesia. So a lot of that treatment is focused on addressing the paraspinal muscles that are involved in those pathways, and that typically will help alleviate a lot of those symptoms. The last 2 models we don't typically use as much as far as manipulation goes, but the metabolic energy model is one that seeks to maintain a balance between energy production and expenditure. And then the behavioral model is actually pretty well aligned with integrative medicine, where stress manifests in increased neuromuscular tension. So osteopathic training today is pretty varied. The first 2 years of medical school consist of 200 to 300 hours of manual medicine. So the first quarter of that is pretty much dedicated just to palpatory skills and developing those. And then later on, you'll go on to learn different treatment techniques, the different indications for them, contraindications for them. The initial training, though, will focus on differentiation of different fields of different tissue in the body, identifying bony landmarks, figuring out what fascia feels like, what bony structures feel like, what muscle feels like. And then after developing palpatory literacy, students will progress to more complex topics such as osteopathic diagnosis, charting, physical exams, and different treatment techniques. The treatment techniques vary pretty widely between different osteopathic medical schools. There are certain schools that will focus on 1 or 2 techniques. There's other schools that will give their students a little bit more of a broader training. OMM is pretty challenging. Students find that it takes a great deal of practice to master the techniques that they've learned, and it's taught in the same scientific manner that pharmacology and every other medical school subject is taught. There's physiologic mechanisms of action for each osteopathic treatment modality, and then there's indications and contraindications. Beyond medical school, DO students or new doctors have the ability to do a 3-year residency that's exclusively in neuromusculoskeletal medicine, which is essentially fellowship or specialty training in osteopathic manipulation, or they could do a 1-year fellowship after like a family medicine or internal medicine type of residency program. Palpation is really something that's hard to master, and it's something that we use fingertips for or finger pads for as opposed to fingertips. And palpatory perception, a discriminatory capability, is determined by the amount of pressure that you're using to palpate. So typically it should be only enough pressure to blanch your fingernail. And then the different appropriate mechanoreceptors will help you identify what types of tissues and what type of dysfunction you're feeling. So here is just illustrating the Meissner's corpuscles and the Pacinian corpuscles, which help you determine your palpatory diagnosis. So a palpatory exam involves a few components. The first is to identify tissue texture abnormalities. So a lot of this will be identifying laxity in tissues, different tone differences, effusions, bogginess, ropiness. It's basically touching the tissue, seeing if there's temperature change, moisture change. It can be representative of an underlying hypertonicity, edema, vasodilation, and it's a lot of times associated with pain, itchiness, paresthesias. Palpatory exam is also used to identify asymmetry of structures, figuring out if there's an underlying crepitus, feeling if they're for a palpable mass, misalignment, or other defects. Range of motion is also a very important component of the palpatory exam, figuring out, it might just be like a finger, how much it moves, how much the tissues move within soft tissue, how much vertebral segments move, are all going to be components of the palpatory exam. And then tenderness is more of an indicator that there is some dysfunction there. How much tenderness doesn't really matter when you're coming up with an underlying diagnosis. Presence of any of these abnormalities within this palpatory exam, as far as tissue texture abnormalities, asymmetry, restriction of motion, and tenderness, has to do with somatic dysfunction, which is basically the indication of OMT. And if you remember back to the tenets of osteopathy, somatic dysfunction is essentially what disrupts all of those tenets. So the unity of body, mind, and spirit, it impairs the body's capability for homeostasis and disrupts the relationship between structure and function. So one of the important components of figuring out what is underlying from an osteopathic perspective with a patient is fascia. A lot of this is sometimes a little bit hard to perceive. It's essentially the connective tissue layer that encases organs, tissues. It can also be subcutaneous, and this is something that can hold various strain patterns and perpetuate for dysfunction or chronic types of issues that a patient has developed over time. So an osteopathic structural exam is going to be performed in addition to a standard history and physical. It basically assesses for impaired or altered function of any component of the musculoskeletal system. If you see two different DOs that are doing this, they might do two completely different exams, but essentially it will get to the same results. It assesses for any underlying dysfunction or asymmetry within the musculature, fascia, and then can also relate it to the lymphatic, vascular, and neural structures that are all tied to whatever is being palpated. It also allows an osteopathic physician to define and locate the sources of person's pain, and then will allow them to assess the functioning of the spinal segments that are involved in the generation of pain. This helps you develop an expanded differential diagnosis and a more holistic management plan, other than giving somebody a muscle relaxer or an NSAID for like low back pain, for example. This is just touching on somatic dysfunction, which I mentioned before. And basically it manifests as palpable changes in tissue texture, tenderness, asymmetry, or loss of restriction or motion. So areas that have an underlying acute dysfunction, you can think of a sprained ankle, typically have tenderness, pain, some edema, some warmth, some vasodilation. And then areas that are afflicted with more of a chronic dysfunction are they may also be tender, but they might have some more ropey texture, fibrosis. Patients will often complain of paresthesia, some tissue contraction, and maybe some itching. So another component of the osteopathic structural exam is looking at an individual's postural alignment and gait. This will help identify any chronic stress or strain patterns. It's becoming more important nowadays, especially as we're spending more time at home and potentially working from home. Our alignment, the height of the computers, ergonomics have a lot to do with, influencing postural alignment. This may also be due to like an underlying anatomic issue, like a sacral base unleveling and underlying scoliosis and increased kyphosis. There are some DOs that will do extensive imaging for like postural studies in the treatment for some of these conditions. A lot of times you can kind of assess what the underlying issue is just based off of feel, and then sometimes using interventions like a heel lift. Pregnancy is actually something that has a lot of structural and biomechanical changes and leads to a lot of musculoskeletal pain and issues that can be alleviated pretty significantly by OMT. So osteopathic manipulative treatment is a direct application of the structure and function tenets. It basically relates back to the fact that structure and function are interrelated pretty closely. It's a manual modality that has multiple different treatment techniques and uses localized force in response to whatever somatic dysfunction was initially diagnosed. So the goal of OMT, and this is kind of an important concept, is to correct, remove, or improve somatic dysfunction and eventually restore function within a patient. It's not so much to resolve pain. So typically following a treatment, a patient may notice some improved pain, but it's not necessarily the physician's end goal when they're actively working on a treatment. It's more to identify the key lesion that's contributing to their symptoms and improving that. Following treatment, patients will always be rechecked based off what their initial somatic dysfunction shows. And they'll have typically palpably significant changes in the function in the structure of the areas treated. Some patients may have partial improvement in their pain, but typically that is followed by several days of gradual improvement following a treatment. Treatments should pretty much be spread out, but how much so is very dependent on the patient. There's a fine line between treating a patient and over-treating them. So while a physician is doing an osteopathic manipulative treatment or OMT, they're constantly listening with their hands, if that makes sense, to assess the underlying response to treatment. So these are some commonly used techniques. There's many more beyond this. There's plenty more that I use. HVLA is probably the closest to what you would see most chiropractors use. So this is more of a rapid thrust technique. Muscle energy actively engages the patient in a specific positioning based off of what their dysfunction is, and the physician is going to use a direct counterforce in relationship to the patient. So there's almost two opposing forces to alleviate the somatic dysfunction that was initially palpated. A myofascial release technique is typically pretty subtle. It works really well for patients that are inpatient, hospitalized. Tissues are basically loaded with a constant force, and this one is a little bit harder to grasp as far as skill because you have to be paying close attention with your hands to figure out when you're gonna feel a palpable release. Counter strain is based off of the principle that dysfunction is caused by a strain reflex, and it's something that is useful in a select type of dysfunction, and it's basically having the patient be rotated or turned or positioned in a way that has an opposing counterforce to the strain pattern that was palpable. And usually this one, you hold the strain pattern, the patient stays in that position for about 90 to 120 seconds, and then they feel significantly better right afterwards. And then cranial manipulation is probably the closest to what a craniosacral therapist does. It works really well for babies with torticollis, people with long-standing headaches. And it's based off of the balanced membranous tension techniques. So the most common adverse effect for OMT is basically temporary soreness and aching. Most patients are recommended to do a little bit of ice immediately following the treatment and then stay optimally hydrated. Most people don't need like an NSAID or Tylenol following treatment, but that's always an option. Less than 10% of patients attending an OMT specialty clinic in a study that they did as far as clinical outcomes and satisfaction reported any adverse effects. There's always the risk of a vertebral artery dissection or a disc herniation or potentially even a fracture in some of those more high velocity types of techniques. So physicians that use those are pretty well trained and aware of like the contraindications to avoid any type of adverse effect like that. So this is a study just based off of 17 OMT specialty clinics. So there were clinics that only did OMT all day long, and it was a longitudinal observational study. It found that patients that received OMT were typically Caucasian, and their most common complaints were lower back pain and neck pain, and that kind of goes along with the fact that most people that are going to these OMT clinics are going for underlying musculoskeletal issues. But like I said before, it's helpful for constipation, sometimes anxiety, and other more less concrete modalities. And the majority of these patients were women, and they were age 65 years or older. Another retrospective study of 1,300 patient encounters, and this was mostly at a family medicine, so a regular primary care practice that happened to be osteopathic. They found that the mean age of patients was around 56 years old, and the number of days between repeat encounters was 29 days. But like I said, that's subjective. 31% of the patient encounters were documented to have some type of somatic dysfunction, and physicians ended up using OMT as a treatment modality in about 25% of those patient encounters. What's interesting with this is about 96% of those patients had improvement in their underlying somatic dysfunction. I think this is kind of a testament to, primary care physicians are pretty strapped for time and kind of overloaded with a lot of other complaints that the patient might bring up. So there's not always time to do like a thorough osteopathic exam or a full-on treatment, although some treatments can be pretty short, like 2 minutes or so. Certain treatments are directed at facilitating a more appropriate autonomic balance. So there's treatments that are targeted towards the fight or flight response and sympathetic techniques. And then there's other treatments that are targeted towards more parasympathetic, so that rest and digest technique. The sympathetic ganglia innervate organs and viscera, and they correlate with certain vertebral and spinal levels. We'll kind of dive into that in a second. So during an osteopathic assessment or a structural osteopathic exam, a physician is going to use palpatory skills to elicit the underlying somatic dysfunction that's contributing to pain. So if a patient with more chronic symptoms shows up with a long-standing complaint, a lot of the tissue textures that are going to be palpated are going to be more doughy, boggy, fibrotic. And that leads to the physician having basically a clue that it's a long-standing chronic issue. So for example, if there was a patient that had a complaint of this pain in between their shoulder blades, that corresponds with, depending on the vertebral level, that'll correspond with underlying GI dysfunction. And it may also correspond with like a history of GERD. So this kind of dives into that a little bit more. So the levels of T1 through T4 are basically associated with the head and neck. T1 through T6 are associated with the heart and lungs. We have your GI, upper GI, stomach, liver, small intestines that are associated with T5 through T9. And then lower down would be T10 to T11 that are associated with more middle GI. And then you can have the prostate associated with like T12 to L2. So if you have a patient that presents with a history of asthma and they have symptoms of like active bronchospasm or other congestion or upper respiratory symptoms, that is going to be more palpable in the regions T1 through T4 and then potentially T1 through T6. And then a patient with IBS, digestive complaints, potentially GERD, well, not GERD because this is middle and lower, but it would be T10 to T11 and then more T12 to L2. So this is an example of a case I had a few years ago. It was a 44-year-old patient that presented with chronic long-standing headaches. She had an extensive workup, had seen neurology. She also complained of some back pain. She had imaging done that was all normal. She didn't have any migraine types of symptoms, so aura, photophobia, phonophobia, anything like that. Typically, her treatment was centered around over-the-counter pain medicines and massage occasionally. She described her pain as deep, dull, and achy, and it was originating in the right interscapular area. She worked a lot at home as a graphic designer, and her job required her sitting for extended periods of time at a computer. She had high levels of stress, which also worsened her symptoms. So on exam, her neurologic exam was normal. Her musculoskeletal osteopathic structural exam showed some tenderness at the right paraspinal musculature, the right suboccipital region, which corresponds with her complaint of headache. And then palpation at the suboccipital region also produced referred pain behind her eye. She also had significant somatic dysfunction kind of associated with the occipital region at the atlanto-occipital joint, and then also at T5 through T9, which was fibrotic, more chronic type of tissue texture changes. So the significance of those findings, the atlanto-occipital joint is associated with parasympathetic innervation, and then T5 through T10, which is where she had essentially hypertonicity when you're palpating, corresponded with GI regions. So that prompted me to ask her if she had any underlying GI complaints, which she hadn't initially brought up. And then she did admit to a history of heartburn that she was taking Tums and Tagamet pretty frequently for. She did not have a history of GERD that was initially diagnosed and hadn't previously been evaluated for GERD or heartburn or ulcers or anything. She didn't have any red flags in her abdominal exam had some tenderness, but no major concerning symptoms. So in addition to OMT, she was prescribed Prevacid, and as she was leaving, she got adjustments as far as her ergonomics, where her computer height should be, breathing exercises to help manage her stress, heart rate variability monitor, exercise to use, and then her headache and back pain improved pretty quickly. It took a few treatments to resolve. And this is just kind of a testament to the fact that an osteopathic evaluation and exam can identify symptoms that show up on a structural exam that a patient may not have brought up and might be seemingly unrelated to her headache, but it leads to overall long-term improvement of health. So initially, I had mentioned the indication for OMT is acute or chronic somatic dysfunction. Typically, what we see people for osteopathic manipulative treatment is going to be musculoskeletal pain, TMJ dysfunction, feeding difficulties in infants, plagiocephaly, torticollis, colic. Postoperative recovery is helpful, carpal tunnel. This is just a small example. It's helpful for constipation, post-accidents and things like that. Relatively contraindications are going to be an active infection, a fracture, bony joint instability, osteoporosis, maybe a DVT, an open wound potentially. This is just a study that was a randomized controlled trial of patients that were asthmatics, which is a common condition that is a reason for pretty significant school absenteeism. And this study found that patients that were given OMT had improvements in their peak flow scores, which is great. And they compared it to a sham treatment. The OMT group had an increase of 4.8% in peak flows, and OMT is something that's pretty non-invasive, it's cost-effective, and they use some pretty quick to implement techniques that are responsible for increasing vital capacity, rib cage mobility, diaphragmatic function, helping improve airway secretions, and potentially some autoimmune function. For low back pain, this was a study that compared OMT to ultrasound therapy, and patients were given 6 treatment sessions of OMT over 8 weeks, and they noted improvements in their low back pain. They had patients in the OMT group had statistically significant reduction of pain scores versus the patients that were in the sham OMT group. As far as these studies go, there's not a real right way to do a sham OMT treatment. Sometimes it's just like laying your hands on the patient. A secondary outcome with that where OMT patients were less likely to report work disability secondary to low back pain. They also use prescription drugs less frequently and were more likely to report being satisfied with their back care. OMT is also a great tool to help improve function, especially as patients progress throughout pregnancy. This was a smaller study. It was a randomized placebo-controlled trial that compared usual obstetric care to with OMT to regular OB care and sham ultrasound treatments. And these patients that were in their 3rd trimester reported decreased back pain when they received regular obstetric care and OMT treatments. In patients with pneumonia, OMT was helpful for, and again, this was a smaller study, but reducing potentially the duration of IV antibiotic use. It was 3 days versus OMT versus 3.5 days in the conventional care group. And they had a little bit of a shorter hospital stay too. As far as barriers to using OMT, this is something that has only started to be studied. It is something that physicians in the emergency department were given a survey to figure out why they haven't been using it. And a lot of them cited time constraints, lack of ability in the ED, unproven benefit in the ED, lack of role models, and lack of supervision and training as far as residency goes. And this is a common theme that's been seen across specialties in patients that also have are physicians that are DOs in an ACGME residency program. They don't have supervision or mentors that are able to teach them or supervise them during these OMT treatments. Another issue within the ED was reimbursement. Physician disinterest, stigma is a big issue. That's kind of improving as far as being a DO, and unfamiliarity with OMT. Like I said, certain schools only teach certain techniques, so they may not be as feasible to use within an ER setting. This was a survey mailed out to 3,000 different randomly selected osteopathic physicians, basically asking how often they used OMT and why. For specialists, they used it less often than family physicians, and the barriers were basically not having appropriate facilities, lack of supervision, lack of time. And this is something that was also showing up in a survey study that was sent out to residents. The promising thing was that allopathic physicians and residents seem more and more enthusiastic about learning OMT and potentially implementing it. And there's now a lot of CME courses over weekends and things that they can hopefully start getting involved with if they were interested post-pandemic. OMT was something that was utilized within the Spanish flu. There was something back in 1918 that was pretty terribly handled as far as components of treatment within the standard of care. Patients that received OMT had a significantly lower, and this isn't a very strong study, but it was interesting, mortality rate. It was 0.25% versus 5 to 6%, which was a mortality rate due to influenza within that Spanish flu pandemic. Rib raising was a technique that was implemented within the Spanish flu, and that it's implemented now. And it's something that focuses on influencing patients within the paravertebral ganglia. And you can kind of see that here. This is a dissection. The rib head is right here, and these are the ganglia. So patients, a physician will have their hands right under the rib head. And it's something that's pretty quick to implement, and it's something that's easily implemented as far as treatment techniques. This is just a breakdown of how to do rib raising. Essentially, the practitioner is lying, their hands are under the rib angles, and they feel for a tissue release, and you go up and down the rib cage on both sides. It's something that's used inpatient a lot. This is a sinus effleurage technique that's pretty easily implemented. It's helpful for upper respiratory complaints, sinus infections, congestion, allergies, things like that. Essentially, you can do it all over your face, but you can target it to certain sinuses. So like your maxillary sinuses, your frontal sinuses, and this is something you could easily do potentially on yourself. A suboccipital release technique is helpful for a lot of underlying headaches, neck pains. It feels really good if you can get someone to potentially try. There's very little harm that you can do, but essentially your finger pads are underneath the occiput, and you just slowly apply a little bit of traction to help those tissues release. These Chapman point release techniques are based off of neurolymphatic reflexes, and they're helpful for patients that have an underlying GERD, sometimes digestive issues. And these are really short. It only takes about 10 to 30 seconds for those treatments to be conducted. And typically, I think I had mentioned this before, you can have some post-treatment soreness. Patients are instructed to drink lots of water, avoid any heavy lifting, ice any areas. And then OMT is a really great adjunct treatment with massage and acupuncture, not so much in the same day, but within the week or to be incorporated within a treatment plan. It's not a good idea to do any type of chiropractic manipulation or any type of another OMT manipulation immediately following an OMT treatment because it needs time to work. If you're interested in getting an OMT treatment for yourself, you can look it up based off your zip code on these two websites. And then there's right now within our office, Dr. Jonas, who does OMT, and it's great. And that's it. Thanks. I'm going to see if I can pull up questions. So I have one from Anna Liggett. She wants to know if anyone using OMT for COVID like they did during the 1918 influenza. I know I'm in touch with some people in Kirksville, and they have an osteopathic hospital there that's still pretty small. So they've been using it over there. And I think it was basically based off of residents doing it on their own. It wasn't like a formal type of intervention. I think PPE is like an issue everywhere. So I don't think that it's going to be something that's studied. I think that's basically it as far as questions, unless someone else has anything else.
The only question that I see on the list is whether or not the slide presentation will be available. And I can just quickly say that we are recording the presentation, and we'll post it on YouTube, and we'll post it on the seminar series archive page, which I can share with you now on the chat. And we'll also email it out to everybody who registered. So everybody in this webinar should be getting the email that I send out. There's also a question in the chat, although we do ask people use a Q&A panel for the questions. There's a question: is there a good resource for patients that detail the difference between OMT and chiro? Oh.
Thanks. The AOA has a lot of breakdown on their website, and in general, especially at our office back at the Osher Center, we use OMT treatment and chiropractic treatment in conjunction with each other. So they're really nice as far as adjunct. OMT has been helpful for more chronic types of issues. It's also harder to get an OMT appointment than the chiropractic appointment, so access is also an issue. But the AOA website has a lot of specific resources. Chiropractic treatment typically is centered around a more acute issue, and a lot of the treatments, Mindy Kramer at our office does a really great job of varying treatments, but most chiropractors will just do more thrust techniques and techniques centered around up and down the axial spine, as opposed to things within the fascia, the lymphatics, extremities, things like that. We have acupuncturists within our office. I personally don't do acupuncture, but that's a really wonderful adjunct to have with a lot of these OMT types of treatments too.
I'll just add for people still on that, and feel free to keep putting questions. We have a few more minutes, but that starting in January, the Osher Center is going to be hosting a series of monthly grand rounds where we're going to have the directors from the 6 other Osher Centers for Integrative Medicine provide presentations. So that's from Harvard, UCSF, Vanderbilt, University of Washington, University of Miami, and Karolinska Institute. So the time is at a different time. It's on a Tuesday in the morning and at midday. And so if you are interested in integrative medicine, then please look out for that series. It's going to be exciting. Part of the benefit of the virtual world is that we are able to access our colleagues from across the world.
Melinda, do you have a URL that you can share with people so that they can either subscribe to get alerts about that or find the event listings?
I'm taking a look to see if we have a URL for ours. Let's see.
In the meantime, I'll also share the IPHAM seminar series
Yes, okay.
Website with our upcoming webinars.
So I just posted here where we post our grand rounds and seminars. The upcoming seminars are not yet listed there, but will be. And then also for people who are at Northwestern, if you are interested in making sure that you get all of our communications, and we do have a newsletter also that goes out monthly, that we do have a membership to the Osher Center that will make sure that you're on the mailing list, and I'm going to post that here too. Both of those are on the main Northwestern University Osher website.
Great. Well, I think because we're not getting any more questions, we can just give people 10 minutes more back of their day. Thank you to everybody who's participating, and to Amrien and Melinda for all of your hard work on this. We really appreciate it. Thank you.
Hi, thanks.
Bye-bye.